Hello, and welcome to everyone joining us today. We are thrilled to have you with us for the Illuminate Hypersomnia Adjunct Scientific Meeting on Idiopathic Hypersomnia, or IH for short. My name is Lindsay Jested, and I am the co-founder and CEO of Sleep Consortium. I'm joined by our meeting moderator, Kim McCleary, and we are broadcasting today from the Washington, D.C. area. Last April, Sleep Consortium was honored to host the Illuminate Hypersomnia externally led, patient-focused drug development meeting. This program brought members of the global idiopathic hypersomnia community together to share their challenges of living with IH, the burdens of the condition and its current treatment, and priorities for treatment benefits that would make a meaningful difference in their lives. In conjunction with the meeting, Sleep Consortium also fielded an extensive survey about the same topics. We were gratified with the community's willingness to share detailed information, and we received a total of 811 responses, making this the largest patient-generated dataset collected to date. The learnings from the EL-PFDD meeting were summarized in a comprehensive Voice of the Patient report. This was published in September of last year. You can access this report on our website. I would like to acknowledge the tremendous partnership of the 12 sleep-related organizations that help to reach members of the IH community around the globe, and the 7 life science companies that provided unrestricted education grants as sponsors of this initiative. None of this work would have been possible without the amazing collaboration with each and every one. You'll see them listed and acknowledged on page 10 of the meeting program, which you can find on the page where you accessed today's meeting. You may wish to keep the program open in a separate tab so that you can reference it for each part of today's discussion. Now, I would like to welcome our moderator, Kim McCleary of the KIF Collective, to connect these milestones from last year to our focus for today's meeting. Kim, take it away.
Thank you, Lindsay, for the opportunity to expand on the valuable insights shared by the IH community through this adjunct scientific meeting. Today, our aim is to apply some of the lived wisdom shared by people affected by IH to the research setting to help build a stronger understanding and consensus for the field. We will focus attention on a few key priority topics that last year's event helped bring to the forefront. The experience of brain fog that so many people with IH described as imposing great burdens on daily life and overall functioning. Challenges that individuals with IH experience participating in research, the array of unmet needs identified, as well as some ideas for collaborative approaches to progress for the field, all in the hopes of improving the lives of people with IH. The agenda for today's meeting and bios for the presenters can be found in the meeting program, which you can find on the page where you access today's meeting. You'll see that we have brief introductory presentations by 3 leaders in the field, as well as 3 panel discussions. Our time together is only 2 hours, so Lindsay and I will keep the discussion moving in an effort to capture as much content as possible. We hope to leave you with new ideas and awareness by the end of today's program. Throughout the session, we invite you to submit written comments or questions using the form on the screen below your video player. Lindsay and our studio team will be monitoring your comments and will bring them into the conversation as time permits. And your written comments will also be reflected in the meeting summary that Sleep Consortium will publish this spring. And now, I'm pleased to introduce our first speaker, Dr. Lynn Marie Trotti of Emory University. Dr. Trotti provided a foundational overview of IH at the EL-PFDD meeting last April, and we're thrilled to welcome her back today to briefly recap some of the important learnings from that meeting and the related survey. Dr. Trotti, over to you.
Thank you so much for that introduction. I am really excited to be here this afternoon to give a recap of the Illuminate Hypersomnia EL-PFDD meeting. So I'm going to start with this Voice of the Patient report for 2 reasons. One is I want to highlight that the full report is available at the Sleep Consortium website. It is a beautiful report full of stories from patients and lots of important data. But mostly I want to highlight this report because it really is the voice of the patient. I want to express my gratitude to everyone who participated in the meeting to be a presenter or to call in with their stories or write in with their stories. It really was an amazing group of people who came together to share their stories very openly, honestly, and bravely, and I'm very grateful for it. As I talk through the results of the meeting, I will also incorporate results of the survey that was done as part of this effort. So this was an online survey in English that was available for 3 months leading up to the PFDD meeting. It was open to adults who either had IH themselves or took care of people who had IH. And so the majority of people, 93% of people who took the survey, were adults with IH. You can see the breakdown there by age, gender, race, ethnicity. It was a robustly represented group of women in the survey, a little bit fewer in the male and non-binary categories. And you can see from the work and school status, a fairly substantial chunk of people who are disabled or not working or attending school because of their IH or doing so part-time. So one theme that came through loud and clear is that the diagnostic challenges, the diagnostic delays really compound the burden that IH itself brings. And so looking at the people who completed the survey, from the time that their symptoms of IH really started to interfere with their daily life to the time they first sought medical attention was about 4 years. And then from the time they first sought medical attention to the time they got an actual diagnosis of IH was 6.5 years, a very, very broad range around that. But really a long delay, both in people realizing they have a medical problem and they need medical attention, but also once people get to medical attention, getting funneled through the right door so they can get testing and an appropriate diagnosis. Looking at the time from the first symptom onset to the diagnosis, the average delay was 14 years, which clearly contributes to the burden of this disease. What are some of those diagnostic challenges? So many people could recall symptoms of IH that were present in childhood or when they were a teenager, but sort of no one realized at the time that those symptoms weren't really normal until things got so bad or life got so challenging that the symptoms really started to interfere with school or work. Or sometimes, concerningly, what brought people to medical attention was a dangerous event like a car accident or near-miss accident. One of the diagnostic challenges, of course, is that sleepiness and fatigue both have lots and lots of causes. And so many people with IH are told that one of the other things that causes those symptoms must be the problem. So lots of people recall being told, well, it must be stress, it must be your lifestyle, it must be depression. All those things certainly can cause symptoms of sleepiness or fatigue. But in this case, we're obscuring the real diagnosis of IH. Many people called out the limited access to people who know what IH is and the ability to get the diagnostic testing that's needed. And then, of course, clinically, we struggle with the overlap between idiopathic hypersomnia, narcolepsy type 2, and hypersomnia comorbid to mood disorder. Those are very hard to tell apart and it creates some problems related to the fact that access to care, particularly medication treatment, varies depending on what diagnosis you have. Another theme that was loud and clear is that idiopathic hypersomnia is not a disorder that impacts only part of life. It is a disorder that impacts every single aspect of life. And so these are data from the questionnaire, and you can see the dark blue is people said, I have a high impact of IH symptoms in this domain, and green is moderate. These bars are pretty high. Most of these domains, most everybody said moderate or high impact. And you can see these are the things I think we think about pretty commonly, like work and education, ability to think and concentrate, but it bleeds over into intimate relationships, social relationships, even things like self-confidence. And although sleepiness is, of course, the mainstay of idiopathic hypersomnia, it is by far not the only symptom that is contributing to impaired daytime functioning in this disorder. So this is again from the survey. 83% of people answering this were medicated for idiopathic hypersomnia, but despite current treatment, 72% said excessive daytime sleepiness still had a high impact on their daily functioning. 77% saying a high impact of impaired quality of wakefulness and fatigue, and then cognitive symptoms, a little over half. So sleepiness, yes, but also impaired quality of wakefulness and impaired quality of thinking. I can't say it better than the patients who participated themselves. A really common theme was the number of good hours is very small. So here, a good day is when I manage to get 3 to 4 hours of wakefulness before my brain starts to shut down. I only have 2 to 4 hours a day where I feel somewhat functional, or I struggle to fit life into the 4 to 8 hours of alertness that I may have 3 to 5 days a week. Making matters worse, it is hard to manage IH. So many people are managing it with a combination of prescription medications, lifestyle adjustments, school and work accommodations, scheduling changes, and the medications themselves. Many people are using combination therapies. They have to change their doses often. They have to adjust the timing of their medications often. And sometimes people are on multiple formulations of the same medication or related medication. And so it is a lot to keep track of. Participants highlighted a lot of burdens to starting treatment and continuing with treatment. Healthcare providers who don't really know what IH is or how to manage it or aren't comfortable with the medications that we need to use for it. Lack of insurance coverage based on the diagnosis of idiopathic hypersomnia or just lack of insurance coverage more broadly. Costs of medications. We have been struggling with shortages of many IH medications over the last few years. Because many of our medicines are controlled substances, there are issues related with that, and when the pharmacy has the medicines and when they can order them. All of these things act as barriers to treatment, separate from the two major issues, which is lack of efficacy for some of these medicines for some people, or development of tolerance over time, and then side effects, both short and long term, of these medications. And so it's probably not surprising to anyone on this meeting that there really are big unmet treatment needs in IH. And so this was a question about how well controlled is IH based on the treatments that are currently available. And 60% of people either said that their symptoms were not controlled at all, or they were poorly controlled, but it was better than nothing. So there is a huge, huge need to do better than nothing. When participants were asked what their top priorities were for better IH treatments, pretty robustly the answer was more good hours in a day. More good hours of awake, alert, and focused. Second most common, relatedly, was relief from the brain fog that often goes along with IH. In the words of SG, I would honestly love to be able to count on 6, or if it's not too much to ask, 8 hours in a day that I would be alert, thinking clearly, and able to actually get things done without needing to take a lot of breaks. I also think it's a shared belief of people participating in this conference today is that people with idiopathic hypersomnia are our most important research partners. There are lots of people with IH who are very motivated to participate in clinical research and clinical trials. 21% of participants had some experience with clinical trials, generally motivated by wanting to advance research on IH and particularly wanting to help other people with IH. And then, of course, for some people to get better access to care and access to new treatments. But importantly, the reason for people not participating was about half of people didn't know there were studies they could be participating in. And about half of people said, well, nobody ever asked me to participate. And those are two burdens that we can fix. Other burdens are a little bit harder, things like studies that require people to stop medications and maybe helping a little bit, traveling to distant or new research sites, and then again, thinking about the limited good hours, using those good hours to participate in research. So with that, I thank you for your attention. I am really looking forward to hearing from my colleagues for the rest of the day, and I will throw it back to y'all in the studio.
Thank you, Dr. Trotty, for the excellent overview of the lived expertise shared by the IH community. Kim and I echo your words of gratitude for the courage and candor the IH community exhibited in sharing so openly for the benefit of all of us to understand the burdens and aspirations of people with IH. Now, let's turn to the topic of brain fog that Dr. Trotti identified as one of the most vexing aspects of IH. Brain fog is also a topic that FDA staff who participated in the EL-PFDD meeting highlighted in our debrief meeting with them last spring. We are happy to have a leading brain fog research expert to introduce the topics, its various definitions, and how researchers are working to better understand its manifestations and measurement. Please welcome Dr. Michael Thorpe of Montefiore Medical Center. Dr. Thorpe, over to you.
Good. Thank you very much for that introduction. I'm delighted to be here to be able to present on this topic of brain fog. Obviously, this is an area which is attracting a lot of attention these days because it's so disabling for patients. Now, brain fog is seen in a whole variety of different disorders, not just the disorders associated with excessive daytime sleepiness, but we see it in many different medical and neurological disorders. It really sort of came to increased prominence during COVID because it was a symptom that was reported a lot by patients who suffered from COVID, and there have been a lot of studies of brain fog in COVID. It's not part of the actual definition for any of the disorders of excessive sleepiness. In particular, it's not part of the definition for idiopathic hypersomnia, although it is widely reported by patients with idiopathic hypersomnia. More than 80% of the participants in the Hypersomnia Foundation registry indicated that they did have brain fog as a symptom. And it is related to cognitive impairment. And this is an area that the American Academy of Sleep Medicine has been particularly interested in. And they regard it as an outcome of interest in improving cognitive function in patients, particularly with sleep disorders such as the central disorders of hypersomnia. Now, when you look at studies that assess brain fog, in general, across many different conditions producing it, you get these typical symptoms that patients would report of things like forgetfulness, difficulty concentrating, cognitive slowness, communication difficulties, grogginess, fatigue. So a whole variety of symptoms that are expressed by patients and that they sort of give under the rubric of brain fog. More specifically, with regards to brain fog and idiopathic hypersomnia, we see that the symptoms that patients with idiopathic hypersomnia report are very similar to those expressed by people with other conditions, medical or neurological disorders. So some of the symptoms reported are lack of mental clarity, groggy, foggy, fuzzy, feeling sedated, mind being blank, in a nebulous state. Patients say it almost feels like sleepwalking during the daytime, and they have forgetfulness, trouble with short-term memory, difficulty integrating information. Now, so what is brain fog? Well, there are several different definitions that have been proposed, and a general definition of brain fog is the one on the slide here. It's a cognitive dysfunction characterized by problems with concentration, memory, inattention, confusion, difficulty understanding spoken and written language, and reduced mental acuity and mental fatigue. We produced a paper on brain fog that was published by the late Rosenberg, and in this we proposed a definition for brain fog in the sleep disorders. And our definition was a cognitive dysfunction that may or may not be linked with excessive sleepiness, but related to some underlying neurological dysfunction, and it reduces concentration, impairs information processing, and leads to a complaint of lack of clarity of mental thinking and awareness. Now, the prevalence of brain fog is somewhat similar across the sleep disorders. If From the Hypersomnia Foundation registry, most of the subjects assessed in this had idiopathic hypersomnia, but those with narcolepsy seem to have a very similar prevalence as those with idiopathic hypersomnia. So about in the mid-80s, about approximately 85% of patients with both narcolepsy and idiopathic hypersomnia report brain fog. Maybe a little bit more in those with type 1 narcolepsy, and maybe a little bit more in those with the idiopathic hypersomnia with long sleep time. Now, there haven't been many studies that have really looked at brain fog in sleep disorders. One real-world idiopathic hypersomnia outcome study called the ARISE study was a internet-based study of idiopathic hypersomnia, patients that had had it for at least 6 months. In the study, they looked at a whole variety of different questionnaires assessing cognitive function and sleep disorders. So included things like the Epworth Sleepiness Scale, idiopathic hypersomnia severity scale, and then functional quality scales like the FOSQ-10, etc. And it was in adults age 75 and between the ages of 21 and 65. The limitations of the study was that the diagnosis wasn't confirmed. So this is sort of a real-world study of patients who report receiving a diagnosis of idiopathic hypersomnia. And one of the things that they looked at was what were the most difficult symptoms to treat in idiopathic hypersomnia. And of course, excessive daytime sleepiness came out to be the most common. But brain fog and sleep inertia were two other symptoms that were very commonly reported by these subjects as being really difficult to get under control with medication. So about 20% reported that it was difficult to control brain fog. Now, in the assessment of brain fog, it is somewhat complicated, and there are a number of factors that contribute to this. One is that we're very dependent upon the patient's interpretation of brain fog. And as I showed you earlier, there are a lot of symptoms that are reported by these patients, and not all patients have all of those symptoms, and some patients express it in different ways. In many cases, patients realize that there's something wrong and that they don't have mental clarity of thought, but they can't articulate the symptoms. It's hard for them to say exactly what's wrong. And so that poses a little difficulty when it comes to assessment. It also is quite different between subjects. So one patient, it may be concentration difficulties. Another patient, it may be word finding difficulties. Another patient may be that it's more of a visual symptom. So it can be quite different between subjects. And it also can be confounded by other comorbid conditions, because we know that the disorders of excessive sleepiness have a lot of comorbidities associated with them. And some that may confound this is depression, which is a common comorbidity in the central disorders of hypersomnia, such as idiopathic hypersomnia. So it may be difficult to tease out what's primarily related to the sleep disorder versus what's related to a comorbid condition. Now, there are a whole variety of different assessments of brain fog that have been reported in the literature. The idiopathic hypersomnia symptom diary is just one that has a mental scale fog included with it, but not validated, hasn't really been published in full. And then there's the idiopathic hypersomnia severity scale, which is a new scale that's been reported in recent studies in the evaluation of medications for idiopathic hypersomnia. And item 11 refers to problems with concentration and memory that seems to capture to some degree brain fog. However, there are a number of other scales that have been used in different conditions, and as shown here on the slide, there's a Polish scale and a Turkish scale, primarily used in patients with COVID, and then a variety of other questionnaires that have been used to assess brain fog. The ones that I think are probably most relevant in sleep are just a simple visual analog scale. So there we don't have to deal with the a specific symptom that the patient has, but the sense that they have brain fog. It gives us a severity scale, but really doesn't tell us about the specific symptoms that the patient may be experiencing. There is the Polish brain fog scale that was developed with regards to COVID, and this is one of the few validated brain fog scales. It's a 23-item scale, and I'll show you in a second this in more detail. And then we have more general scales that have been used in the disorders of hypersomnia, assessing cognitive function, such as the British Columbia Cognitive Complaints Inventory, a more well-established but shorter assessment of cognitive function. So this is the items in the Turkish brain fog scale. And I'm not going to read through these, but you can look through these and you can see that most of the symptoms that seem to have been expressed by patients with brain fog seem to be covered by this. There is one item there related specifically to sleepiness. I've felt sleepy, item number 6. And there is an item that is fairly diverse in its sort of etiology. I found myself getting annoyed, but other than that, most of the other items on the scale seem to be pretty well the type of symptoms that patients with brain fog and also those with idiopathic hypersomnia tend to report. So this may be a scale that could be adopted by the sleep community in the assessment of brain fog. The British Columbia Cognitive Complaints Inventory is another one. It only has a few items, as you can see here, 6 items, but these items do address the concerns that we see with brain fog. You assess it over a prior 7-day period, and then there are questions related to how it impacts on their functional ability during the daytime. So this is a relatively short cognitive assessment, but it just assesses a cognitive impairment that may be related primarily to just sleepiness or to other neurological features that patients with narcolepsy might have, not specifically addressing brain fog. So in conclusion, brain fog's a common complaint in idiopathic hypersomnia. It's described differently in individual patients, so it's not the same thing to everybody. It is regarded as one of the most difficult symptoms to treat in idiopathic hypersomnia. And currently, we really have no validated scales of brain fog in the sleep disorders. So we need to move ahead with that and to get more specific information. So further research on brain fog is definitely needed. So I thank you for your attention, and I will pass it back to our moderator. Thank you.
Thank you, Dr. Torpy, for providing such a helpful overview of the study of brain fog. And I'm pleased to be joined by our first panel, bringing additional expertise to the discussion of some of the foundational aspects of brain fog that Dr. Torpy introduced. And today we have with us Kieran Maskey, Anne-Marie Morse, and David Plant. Unfortunately, Dr. Lucy Baratow is battling the flu and is unable to join. So thanks to our panel for carrying the discussion today and filling in the gap that I know we'll all miss from Dr. Baratow's experience. Welcome. Great to have you all here.
Thank you for having me.
So Dr. Torpy addressed different ways in which brain fog is used by patients and defined more formally. So I'm curious, how does this varying terminology used by researchers, clinicians, patients, affect efforts to better define and study it? And Dr. Plant, I know when we met last week, you had a really crisp metaphor that I think might frame this discussion nicely, if you don't mind starting us off.
Well, I think that for me, one of the things that's very interesting about brain fog is the fact that it is a description of sort of something that everyone experiences, right? So everyone's been out in the fog, either in the morning, especially, and you can't see as far as you normally would. you can't be as involved or connected to the world as you normally would be. So I think there's something even about the metaphor of the word fog to describe this symptom that we think is emanating from the brain and related to cognitive function, but really sort of reflects sort of this disconnected or sense from the outside world that I think we have to keep in mind when we talk with patients and sort of try to understand this particular symptom.
That's really helpful. And Dr. Morse, you brought up the fact that the term brain fog itself sort of initiated by patients and then sort of made its way into the clinical and research settings. Help unpack that idea for us.
Yeah, one of the things that I think is important, and I would be amiss since Lucy is not here to share her description as well, is that in the United States, we definitely had seen this term become popularized in medicine through the introduction of patients coming to clinic, not just sleep clinics, but a variety of different specialties describing this type of complaint. Now, the inverse that we learned from Lucy when we had been talking about brain fog is that the opposite seemed to have existed for her in her practice, where patients were not describing this phenomena, but they were asking the patients of, are you experiencing this term of brain fog? And in fact, there was even a difficulty in being able to establish a translation that would be adequate to be able to really resonate in regards to the conversation. And so I think that's very interesting. The secondary piece is that there's a lot of attention on brain fog. And the reason that this has become even more popularized is related to the post-COVID phenomena. And so I've been very fortunate to work with companies like Trend Community that does social media listening and data analytics around conversations that patients are having for us in the medical community to better understand what our patients' needs, what does that journey look like. And what's interesting is to know is that although this is a term that is very popular in use now, it pre-existed COVID. And so this is a symptom that really is pervasive across a variety of different medical conditions. And I think David really acknowledged something that's quite important, is that we have this perception, and I as a neurologist definitely have a bias, of that it comes from the brain. However, we do see this complaint in non-brain based disorders. So we see it in celiac disease, inflammatory bowel disease, you see it in renal disease, you see it in other disorders. And so whether that's representing a gut-brain axis or some other interaction, or that there are multiple feeders to the experience, is really one that we're still continuing to try and unravel.
So that brings up a great next question for all of you, and maybe Dr. Maskey, you can start us off. Do we have consensus in the field about whether brain fog is one thing, or are the lines pretty blurry about it, whether it's one thing in IH but a different thing in celiac disease? And especially in IH, where you've got sleepiness, fatigue, and sleep inertia that all impact physical and cognitive functioning. So how do we tease this apart?
Yeah, I can start. I think that it is a common experience, as Dr. Morse had said, across different groups, that they're really describing a constellation of a number of symptoms that, culminate in this feeling of brain fog or mental cloudiness. But no, I don't think anyone really has like a clear test or, even a survey methodology that fully has been accepted across the fields to capture it. I think some of the surveys that Dr. Thorpe had mentioned are being developed into outcomes for clinical trials. So I think treatment sensitivity will be an important measure to establish maybe a gold standard, if you will, but it's early days for that.
Yeah. Dr. Plant, Dr. Morse, anything to add to that maybe?
Well, I guess I would add that I think that one of the real challenges, just to build on what Kieran was mentioning, is that no one can say exactly what brain fog is. There's so many different aspects and dimensions to it. And really sort of wearing my clinician hat, what becomes very important is how the individual patient is experiencing or describing their brain fog, because it's probably going to be very hard to develop a singular scale to capture something that has so many different aspects. So hopefully it would capture all the different aspects that are involved, especially in idiopathic hypersomnia. And I think to a certain degree, one of the things that we'll have to do as a field, and Dr. Thorpe sort of alluded to this in terms of more research, is to also use some maybe methodologies that we don't always use as much in medicine. Like we like to measure things objectively and look for changes, but I think we need to take a step back and really spend some time doing some qualitative research, talking with people, about how they experience brain fog, what that means to them, because the term means so many different things to different people. And then even as a starting point from the clinical standpoint, if somebody says they have brain fog, I like to try to follow up with, well, how do you experience that? What's that like for you? So I can at least have some sense of what they're communicating, because people may be communicating different things by using this sort of broad term.
It's
So,
almost
so
like
one thing that I would like to add to is that the added complexity when you're talking about a phenomena of brain fog is that we are all making a suggestion that we're going to ask patients about what it is that they're experiencing, but they're describing to us that they have a primary cognitive complaint. And so sometimes a word finding to be able to adequately represent what they're experiencing is lacking. And so I do think that when we're talking about how are we measuring this and how are we measuring potential improvement, the other side of it is also ensuring that we're not invalidating the lived experience of anyone who's actually describing because they don't meet a predetermined metric. Secondarily, when we're talking about how do we develop a scale to be able to assess for brain fog, we just described that there's multifactorial probably etiologies. And when you're talking about individuals living with a hypersomnolence disorder, and this is really true across sleep disorders and circadian disorders, it generally is not one alone. It's generally not one sleep disorder, and it's generally not one medical disorder or psychiatric disorder. And so it becomes something that is difficult to disentangle. I think if we were to start with something most rudimentary, it would be simple questions like, what can't you do because of your brain fog? And that now gives you a starting place of, well, let's try to understand what are drivers that we can do behaviorally, pharmacologically, through rehab specialists to be able to recover these processes. And so I do think it's with exquisite caution that when we're talking about the development of either scales or biomarkers, of understanding that this probably is not a fixed outcome and that it probably changes based on biologic age. It probably changes based on baseline cognitive abilities. And it also probably changes based on where you are in terms of other chronic medical conditions, as well as superimpose other acute conditions. So I think that it's something we're all very interested in doing, in understanding and helping to improve. But it's also something that we have to continue to reevaluate to ensure that we're actually not introducing harm by minimizing the disability that people may be experiencing related because they are not quote unquote severe enough to warrant either a treatment or an acknowledgement of where they're struggling.
I want to come back to this really important topic of measurement and, how do you capture what is most important to patients? That's what this whole session is about. But before we do that, I want to just remind participants who are watching this meeting that we welcome your written comments using the comment form below the video player. And we'd love to know, what would you add to this discussion? What thoughts and contributions might you make? So let's go back to that idea of measurement, and you've brought up a number of really important points about the ways that our current methods for measuring the presence, the frequency, the severity, even sort of the elemental nature of the way that people experience brain fog is happening presently using some of the assessment tools that Dr. Torpy mentioned, the 23-item Polish scale, the 9-item scale from British Columbia. So let's just expand on maybe what some of the limitations of those kinds of tools are, thinking about, Dr. Morse, your comment that people have cognitive issues, and how well can they sort of reflect on what happened 7 days ago or 30 days ago, often that they're able, asked to do. How are you all thinking about that? Dr. Maskey, I'll give you the first shot at this.
Yeah, no, I think that's a good point. I think the time frame of reflection is important. A lot of the surveys ask about cognitive demands, say in like a work or school environment. And so, for school, for instance, there might be summer vacation where there could be variances in the outcomes that are reported. And I think, too, the purpose of these scales is important. I think Dr. Morse touched on a really important concept of, when we're trying to understand or conceptualize the real severity of a condition like idiopathic hypersomnia, understanding the functional limitations, and being really agnostic about what the contributors are. Like maybe it's depression that's contributing, for instance, to brain fog, and not so much the symptoms, but the end result is still brain fog. So I think those are sort of the broader scales would be useful. But when we're looking to implement it into like a clinical trial or something like that, I think that's where there might be needed some strategy about what can actually change with a particular compound or a variance in sleep duration or sleep inertia or whatever. And then you might get a smaller scale, if you will, that can be used to assess treatments. And does that reflect the full experience of brain fog? Probably not. But you are, at least we're moving forward in helping one subset of what we think is brain fog. And to me, that's forward thinking.
And it may also even be necessary to sort of prescribe, like we're going to measure this in the morning versus the afternoon. As we heard from individuals, they have better times of day and very few hours. Are you trying to catch them at their best or catch them at their worst? And what other things need to be controlled for? Dr. Plant, any observations about these assessments and how they're
Sure.
used or not?
Yeah, I think that all the scales that we've talked about so far are, they all have plus and minuses, but they're all fundamentally self-report of sort of a subjective experience of brain fog, which does not to mean that they're not very important, but I think the challenge is balancing subjective and objective measures. So in medicine, oftentimes, ideally, we like to have something that is measurable, not just based on self-report, be it a cognitive task or something that is done that isn't just people's perception of what's happening. The challenge with that here, and this comes up a lot with other disorders where there may be discrepancies between subjective and objective measures, is a lot of the objective measures we may try to use to measure brain fog or other cognitive complaints oftentimes don't necessarily pan out or are identified in central nervous system disorders of hypersomnolence. So that's a real challenge. And some of that may be related to sort of the amount of energy or mental effort it takes to complete the task. So a lot of patients with idiopathic hypersomnia are very intelligent, quite bright people, and they may have higher motivation to do well on a task and look like they're totally normal because they're able to muster that effort, for lack of a better term, to do well, but that doesn't mean that there isn't an impairment. So I think that's one of the real challenges is sort of figuring out objective and subjective self-report and how to sort of marry these things together as we understand brain fog more broadly.
Dr. Morse, I saw you nodding vigorously to that idea of the mismatch between their ability and what shows up in these assessments.
So I think that this is data that has been demonstrated of that even when you're looking at the workplace activity and you compare an individual who has narcolepsy versus idiopathic hypersomnia, an individual who has narcolepsy is going to be more likely to have a higher rate of absenteeism from work. They generally have more inconsistency in being able to get there. And that has to do with the inconsistency of their predictability of day to day. Or an individual who has idiopathic hypersomnia may have a lower degree of absenteeism, but has a much higher degree of impairment due to a lack of presenteeism. I show up because I need to muster that strength to physically be there because there's a judgment of that. But I may not be able to do all the work that I would like to accomplish because it's so challenging. So I do think that this is very, very true of what David has shared, but I also think it's important to frame up that some of the things that have been most impressive to me when speaking to individuals who have idiopathic hypersomnia is when they share experiences like it is a task to shower. And for many of us, we don't think twice about that. The only time that I've thought about that in my life is when I was a brand new mom with a newborn, or when I was in residency and I was coming off of a night call. My husband used to yell at me for getting in bed in my scrubs. And it was because I can identify with that experience of I can't even fathom taking off my clothes and getting in the shower and grabbing a bar of soap. And so when we're asking about how are we going to measure these things? It is a matter of then saying, are you even going to have measures that accurately represent if we're only going to get their best moments? And so I do think it introduces the opportunity of saying, we now are in a period where perhaps there are other ways to measure surrogates of brain fog, through wearables. And those may be wearables that are EEG wearables, looking at the actual brain activity of the brain, but it may even be as simple as things that people are utilizing on a day-to-day basis, like their Fitbit or Oura Ring or Apple Watch or you name it. And I'm not saying any of them to say one is better than the other, so please don't go and buy any of them based on that, on those statements. But what I'm stating is that they are giving us an understanding of where your level of activity is. And perhaps when a person is experiencing a more severe degree of brain fog, they are going to have slower activity. They are going to be more reserved. They're going to be more likely to not engage. Or we may see the opposite, that because of their brain fog, they're feverishly walking around and doing things, but it's misdirected. And so understanding this more continuous lived experience is so much more important than for us to be able to get these episodes that may not accurately represent. And I think that we really are going to need to have continued patient engagement and understanding of where that is. Now, to balance that, there's also the academic side of my brain that goes, well, we do a terrible job in clinical practice anyway. I run a division of child neurology, and I would love to have the access to being able to do neuropsychological assessments on every single one of the children and young adults that we see in this practice, because I can guarantee there's going to be variations that would introduce opportunity for me to say, what kind of accommodations will allow you to excel despite whatever your variation is. The challenge there is even something that is already validated as a way of measuring cognitive performance is limited in terms of access to be able to say, do we just even see something baseline rather than saying repeated, that we can frame out something else to be able to follow over time.
Really important thoughts, especially I love your suggestion that we look to patient partners to help unpack and do some sense making about what the data is showing us and how they might explain it in a context that isn't really, understandable unless you know what's happening day to day, and that all that activity was really going from place to place in the house looking for your eyeglasses or something. It wasn't vigorous, purposeful, directed attention. So that also gives us sort of a nice segue into maybe some ideas about where we understand brain fog measurement science moving to, away from, or in addition to sort of paper and pencil or digital assessment tools, to things like imaging, biomarkers. You mentioned wearables, and what are some of the other approaches being explored as a way to maybe better understand brain fog and to measure it?
I can start. I mean, I think from a research standpoint, anything is possible. But it does seem like wearables, as Dr. Morse mentioned, is important because it is something that fluctuates across a day. And multi-sensor wearables, I would argue, would be helpful. We don't know if this is autonomic. We don't know if this is, activity related, brain related, or whatever. So I think to accurately study it, that's something that could be helpful. But we also need assessments that are available to patients through the day. If there's, these fluctuations that are occurring morning to evening, devices that send you like a little ping on your Apple Watch or wristwatch device, something that's on you at all times to, give a sense of how you're feeling at that moment. So we call those momentary assessments, might be helpful. I remember hearing a patient talk that she had an Apple Watch just to find her iPhone. So even having like an iPhone might not be, an appropriate way of or phone-based devices might not be appropriate. We have to look at, things that are on a person that are easier.
And integrated into their everyday life, not an additional burden that takes away from the other things that they want to do. Dr. Plant, some thoughts from you maybe?
Oh, I was just going to say, like, I think, with brain fog is even more complicated than sleepiness. And sleepiness is really hard to measure. Like, we don't even have great, like, all of the tools that we have that are objective measures. Again, sleepiness is sort of this multifactorial, multidimensional problem. So it's even more challenging, I think, with brain fog, in the sense that you need some kind of a scale or instrument that quantifies the personal experience of brain fog and its different dimensions. And then you need to map that onto whatever physiologic variable you would be looking at, whether it's brain-based EEG or heart rate variability from a wearable or whatever that would be. So it's a very challenging thing to marry. And I think it's important to keep in mind or reflect on the fact that we still need to do some of this work also in some of the other really important aspects of hypersomnia as well, beyond brain fog. So it's a very difficult nut to crack, so to speak. So I think that we need to sort of try to look at individual discrete measures of brain fog and map them onto discrete sort of changes in physiology to try to unpack it. But it's very challenging. And then also, I think I totally agree with the idea around like momentary assessment and things like that, and app-based ways to understand variability. But then there are even challenges with those types of things where people oftentimes will get an app and use it quite a bit at first, and then over time sort of stop using it. So there is also a fatigue associated with these types of technologies as well, which you'd imagine in people with brain fog might even be worse, right? So harder to measure it, and it is maybe their disengagement with the app is somewhat a measure of brain fog. So there's many different layers to trying to unpack this. But I think fundamentally we have to go back to finding discrete elements of brain fog and trying to map those onto other discrete elements of physiology to connect the two to get some traction.
Really important. And Dr. Morse, I know you've been following and maybe helping foster the research of cytokines and other things that we might be able to measure in the physiology to help us better understand this phenomenon.
Well, I think that when we're talking about inflammatory contributors to not only cognitive performance, but also to sleep-wake disorders, this is really a very complex phenomena, because we are seeing that not only are there circadian variations in terms of those types of profiles, we also have patients' reports of circadian variations that are unique to an individual and not necessarily widely applicable to what their experience is like. In addition, we also know that there are significant cytokine involvement in terms of the exaggeration of our homeostatic sleep drive, which is going to make us more sleepy. There also are specific interleukins like IL-6 that have been attributed to increasing the permeability of the blood-brain barrier, which introduces a whole nother component that we don't fully understand. And so there may be an opportunity of understanding by utilization of some of the profiles of these type of markers as to whether or not there is any type of inflammatory component, whether it is based on a hypersomnolence disorder or beyond, that may be a shared phenomena that could explain why these types of things are occurring.
Great things to hope for in terms of maybe having some objective things that could be layered on top of the more subjective or momentary types of measurements that you all described. I know we're coming to the end of our time together. I want to give each of you the chance to sort of answer a question a little more aspirational in nature. Let's pretend we had the magic wand out and you could wave it. Do you see as a key research question or a tool that we could dedicate resources to that would really help us get our arms or fingers around this concept of brain fog, that would contribute to progress in therapy development, care, and ultimately, improving the lives of people with IH? And Dr. Morse, I'll start with you.
Sure. So I always look at the sky's the limit, right? And so with that stated, I think that it may be trite to say, but we're in the era of big data and artificial intelligence. And so what I would be looking forward to is saying, how can we take information that may be available? Maybe it's a collation of polysomnography data, for instance, and being able to have artificial intelligence looking at, is there specific neurocognitive profiles that we see by that? Maybe it's not the polysomnography. Maybe it's actually taking the full day and having things like ambulatory EEG and applying artificial intelligence, machine learning, artificial intelligence, understanding it. One of the things I've learned is that you will miss 100% of the time the things that the eye can't see. And so with that stated, machine learning and artificial intelligence has already proven to us that there are a lot of very, very specific electrophysiologic signatures that are informing on different types of etiologies and also different symptomatology. And this may be one of those opportunities to say, why don't we use data that is already existing, but analyze it different than what we've thought of before?
Fantastic. Some great ideas there. Dr. Maskey, how about you?
I mean, I think that I'm coming from a more practical standpoint and just what we can do in the clinic right now. And so I think using tools that are accessible and relatively inexpensive is really, I think, a goal here in order to collect information that, is digestible to the clinicians as well as feasible to complete by the patient. And so that is something that I think we have to work towards, but I am excited about the multi-sensor wearables and with these kind of momentary assessments that seem feasible to implement in such settings.
Terrific. And Dr. Plant, you get the last word.
All right. I would take a step even back a little bit further and just say I think the first step would be to really have a validated self-report instrument of brain fog that is very specific to the idiopathic hypersomnia disorder, right? So that we can use that in different clinical trials and as an outcome measure. It may not be perfect. It's not going to capture everything, but hopefully it captures enough of the dimensions that are experienced by people with IH that then we can use that to then leverage it in these other sort of more applicable sort of like pie in the sky types of research things like artificial intelligence and machine learning and things like that. So that's kind of where I would like to see things go from here.
Well, I love the varying levels of aspiration that is sort of from low, medium, high, things that are maybe more tackleable and low-hanging fruit, if you will, all the way up to the more ambitious integration of all different data types through artificial intelligence tools. So that is really a tremendous set of things to think about. So I greatly appreciate you one and all for sharing these perspectives with us, being part of this Illuminate Hypersomnia initiative, and certainly wish we had more time together today to keep going on this topic that's really generated such intriguing insights and possibilities. And Lindsay, with that, I'll thank the panel and hand it over to you for our next presenter.
Thank you, Kim. Research is at the heart of better understanding IH, expanding treatment options, and improving care and patient outcomes. However, at the EL-PFDD meeting and through the survey, we heard about challenges that people living with IH face in participating in formal research studies and clinical trials. We now turn to exploring some of those challenges with the objective of collectively working to mitigate them in future studies and propel science. It is an honor to have Dr. Emmanuel Mignot from Stanford University with us today. He is among the world's leading experts on central disorders of hypersomnolence and is a caring physician for so many people with IH and narcolepsy. Dr. Mignot will introduce this topic, focusing on a few key challenges that he has observed. So thank you for being with us today, Dr. Mignot, and over to you.
Hello. Thank you so much for having me introduce this session. And thank you, Claire and Lindsay, for inviting me to cover the difficulties in conducting research and the barriers in doing so. I think you will have a lot to discuss. I want to talk a little bit about the patient experience, which I think is really essential. So there is the patient experience and I would say the difficulties for patients to enroll or participate to research. So the positive, I would say, is that in general, and they always will try to make it very easy for the patient to participate, or they will try their best, because I'm very aware of that. And my experience has been that they are very supportive for whatever you ask them to do to help patients to enroll or to be part of a clinical trial. They don't want it to be difficult. They really want to make sure the patients are happy. However, often the problem is with study design. Sometimes these companies want to be too perfect, and by doing so, they shoot themselves in the foot. They put so many criteria for inclusion. The patient cannot be a BMI more than 35, and they cannot have sleep apnea more than 5, and they cannot have PLMI, and they cannot have, and then at the end, nobody can be included. And that creates a lot of problem. Often it's improved after with some process that we could amendment. So they amend the protocol, but then they have to go through the whole process of approval, which slows down often some aspect. So I would say that the study design is extremely important. And, but I mean, often companies do fine. It's the most difficult is when you're the first one, you know? When you're the second one, usually they just look what's on clinical.gov and then they copy the protocols. It's pretty awful for the people who really started it, but they copy and then they try to figure out how to improve it a little bit. But in general, I think the inclusion exclusions are the killers, you know? If it's too strict, of course, it's bad, and because nobody can enter. And if it's too loose, then that can produce other problem, obviously, and even bad science and bad conclusion for the trial. So it's not possible, of course. What I think is difficult for patients in general is stopping medication. You know, like, because these patients now with narcolepsy or hypersomnia, very often they are reasonably well treated, or if they're not well treated, the treatments are helping. So you are in that situation where how do you really make sure that this patient will benefit from your clinical trial? I mean, your duty as a doctor is to make sure that this clinical trial, you don't want to do them just to do clinical trial. I do want to do them because I want my patients to benefit from them. And so I have to figure out the patients that are going to benefit. And sometimes if the protocol is a burden, it's very difficult to justify to myself and to the patients, of course, that this is useful for them. And stopping the medication is the hardest. So, but I think now people have good experience, at least for narcolepsy and hypersomnia, how long, and they try to reduce the time where you stop the medication. I think in some cases, they probably don't go back to baseline. You know, for example, for narcolepsy with Xyrem, you know, the first trial we were stopping we were proposing to stop Xyrem for 6 months to go back to baseline, but that was atrocious for the patients. They couldn't really, I mean, they gained back the weight, they just relapsed everything. It was impossible. So now it's only, you know, months or so, but probably patients don't really completely go back to baseline. So it has some, you know, negative. So I think designing the protocol is really essential. And then for the patient, there is a burden of the protocol. You know, how many visits, you know, are going to occur, how much travel is going to be, etc. How much is going to be disrupting to their lives, their work, etc. And again, in my opinion, the company make it really as attractive as possible. They would, I mean, at least I insist that they would pay for Uber, for anything that would be like an inconvenience for the patient, because I want my patients to not worry about anything. It's not possible. And right now I know that have patients on placebo, for example, which is another problem. If they're on placebo for 8 weeks, it's really quite difficult for the patients to you know, to be in that arm. But often that's another thing to insist is to make sure that at the end of the trial, all patients, even those that are on placebo, can get access to the drug. Because what is the incentive of a patient to go through a trial if they get on placebo, and then after, at the end of the trial, they can't continue? So generally, this is fixed because you always have what's called an extension study. But I think that's another very important aspect of any trial that's being designed. I think there's big hope in general for the patient experience to improve a lot through the use of remote technology and the use of virtual kind of much more like at-home measurements. And this will be an entire field that I'm not going to talk about because it's a very long discussion. But again, I think there are definitely some burden. For example, some difficulties. For example, the fact that you cannot work across states for clinical trials makes it, you know, very, very difficult. And then the patient experience, which in my opinion, companies are taking a lot of care in trying to fix, but there is a part that's impossible to fix, which is just that this patient had to stop medication and there is some discomfort involved. You have to select your patients that will benefit, and you have to make sure that and that's really trying to design a protocol that's not too burdensome for the patient and to compensate them well and to make their life easy. So I hope that this introduction will get you going in a lot of discussions. But of course, that's only my point of view, and I'm sure that there are other things that I forgot. So thank you so much for asking me to introduce this topic.
Thank you very much, Dr. Mignot, for leading off discussion on this topic. And we are now joined by Omavi Bailey, Bruce Corser, Yves Devalier, and Anne-Marie Morse. Thank you so much for being with us today to discuss considerations for recruiting and retaining people with IH in research studies. And I know this is something each of you think a lot about as you conduct research studies at your institutions. So one of the key barriers that came up at the ELPFDD meeting in April with regard to participating in research is that people just simply weren't aware of research opportunities and clinical trial opportunities. So we want to start with what each of you might be doing to help raise awareness and interest of clinical trials among people with IH. And Dr. Corser, I know when we were preparing for this conversation last week, you were talking about some regional meetings you're doing to try to get the word out beyond your local sort of catchment area there in Cleveland. Would you mind starting us off with how you're approaching that?
So I'm actually located in Cincinnati, but what we've been trying to do is reach out to other areas, geographic areas in close proximity. For example, there's really no clinical trial sites in northern Kentucky, so we're targeting Lexington, Louisville. We're also reaching out to Indianapolis, Dayton, Ohio, Columbus, Ohio. So yeah, we're trying to expand our catchment area. But I'll tell you, advocacy groups are incredibly important. They serve as the intersection between patients and sites. And so I think the advocacy groups play a very important role in disseminating information about clinical trials. So it's very important for these advocacy groups to serve that function.
You're so right about that. They are the trusted sort of party within the community and can be an important conduit for that information. Dr. Bailey, I wonder how you are approaching this topic of elevating awareness and getting the word out.
Well, we do quite a few different things. The most important thing we do is really engage the community. We do have a community sleep center. We have a few sleep centers here in El Paso, Texas. And while there's about a population of around 800,000 people and a second largest Army bases here as well. So there are quite a few people, but it's a physician shortage area and a very severely underserved area. So there's two things that have to be done effectively. You have to communicate in terms of educating the population about what is hypersomnia, because it does oftentimes get misdiagnosed, but also reaching out to providers to also let them know that these conditions exist and there are options and new treatments, et cetera. So we engage both the providers as well as patients in the community. We currently run commercials on local television because we have a population that watches local TV. And so we also do some social media outreach. We have events with providers where we speak and educate on the newest science and recommendations around hypersomnia. And like as was mentioned earlier, advocacy and those who do advocate are really important partners to have to help reach and engage the community.
That's great to hear, especially in an area like El Paso that, as you said, is a shortage area and maybe harder to reach than more urban settings on the coasts. Dr. Morse, the subject of social media has come up. I know you've got your own presence in social media and rely on that a lot. How do you tackle this subject?
So I think when looking at social media, it represents such an exquisite opportunity, not only delivery of information, but understanding. And so I not only utilize social media as a method of delivering information, it really is an opportunity for me to understand where care gaps are. And so what had started out as an N of one, I went there because I heard my patients saying they've learned X or Y or Z on the internet or on a certain social media site. And some of it were truths and some of it was mistruths. I then went and wanted to understand where are those gaps? Where are those opportunities to provide intervention or opportunity? And what that then translated into is having even more understanding based on data analytics when you're able to look at this more globally. So there is this very unique opportunity that I get to be a part of with social media by being able to better qualify and quantify what is the lived experience, where are the knowledge gaps, and being able to deliver the opportunity of there are new clinical trials. These are the locations that you want to look at. So whether it's clinicaltrials.gov or checking out specific pharmaceutical companies' websites to be able to understand. So my efforts are not targeted to just specific recruitment to where I'm doing clinical trials, but really more of how do we not only get people to participate, but how do we improve the quality of the clinical trial that people will be excited to be a part of because it actually is acknowledging the things that they're suffering with.
Great comments. Thanks so much. And this has been so far U.S. focused. And Dr. Devallier, you are in France, and maybe things are contextually different there. What are some of the ways that you think about outreach and awareness in terms of attracting and retaining participants in your clinical studies?
Yes, good point. I'm the only one outside of US, as always. So it's different style, probably different background and education program. And I'm not at all involved in social media, unfortunately for my patient, could be. But I have 3 points related to that. It's a rare disease. So for sure, we need to train and to educate general population that they may be affected with this kind of disorder because it's rare, the GPs will not think about it. So there is long delay to be diagnosed, to inform that being sleepy all day long, it could be related to a disease. IH is one, but narcolepsy is another, but there is other condition that may trigger sleepiness. So for sure, we need to educate general population that sleepiness is a symptom that could be related to a disease. But social media, if you open the door in France, we have a waiting list for patients to come to see a university center dedicated to sleep problem. And at the end of the day, if you open the door, you will have 2 years of waiting list. So at the end, it's not nice for the patient. You need to really focus on the one who need to be managed with drugs or with behavioral therapy, but to recognize what is a symptom, what is a disease. And we need to improve the diagnostic criteria across different countries to be sure that we are facing the same problem.
So you bring up a really good point about just the challenge of getting to the point of being diagnosed, which is sort of an entry criteria for research studies. And we also heard at the ELPFDD meeting about, people just may not have, even once they've identified or been diagnosed, they may not be familiar with what the formal criteria are or have access to the results of their diagnostic testing. And so when they see a post about a clinical trial and read through the inclusion and exclusion criteria, that can, sort of open up questions about, I don't know if I fit this or not, or I've got sleep apnea on top of this, or they thought I was depressed and now that's in my medical record, like, do I fit or not? So what are some of the challenges with the inclusion and exclusion criteria that may affect whether you can attract and identify appropriate patients for a given research study, given some of those challenges with identification? And maybe Dr. Devallier, I'll invite you to start with that.
I can start. I think you write a very important point, how to make a good diagnosis. And the patient may be comfortable to reading some article and so on that they may be affected with the disease. and the physician may be also in favor of this disease as a clinical judgment, but this is not enough. You need to record something, objectively assess whatsoever it is, depending on where you are. If you are lucky to have a long-term EEG recording, but it could be actigraphy, it could be whatsoever you want, but you need to objectify something. If not, you will be in trouble, because, as an example, if you want to understand the disease in terms of the pathophysiology, if you disagree in terms of inclusion criteria between centers, the results will not be replicated, and it could be not due to the wrong results. It could be just to heterogeneous of the population. Same story for drugs. Who are good responders to the drugs? We may expect that there is many factors that may be that one guy is better responder than another, but again, we need to come back to the definition of the disease. And currently, we do not have very good biomarker for IH. There is some, but it's not shared between labs for many reasons. Again, we try to convince that long sleep recording is one, but it's costly, and there is many issues related to that. But I just want to make a note that for narcolepsy, it's a different story. Narcolepsy type 1, we do have good biomarker. One example is HLA. If you are HLA negative, it cannot be, with very rare exception, narcolepsy type 1. In current trials for orexin agonists, 1/3 of the patients are HLA negative, but they are included as a screening test. So even if biomarker exists, it doesn't mean that the physicians are good to diagnose the patient. So we cannot just trust the clinical judgment. We need to do more, and we are here to educate the population, hopefully.
Thank you for that. It's the heterogeneity of the population coupled with maybe the way diagnostic criteria are applied at different centers is certainly a challenge. Dr. Corser, what would you like to add to some of these challenges in the inclusion and exclusion criteria aspect?
Well, I clearly agree with Dr. Duvalier, but there's definitely a couple phenotypes with idiopathic hypersomnia, the long sleep phenotype, and then the normal sleepers, the people that sleep a normal length of time but feel chronically sleepy throughout the day. So I think one of the important things is to recognize that IH has been regarded as a very rare disease. But if you look at the current diagnostic criteria, there's probably 1% to 2% of the population that would qualify for the diagnosis of IH using the current diagnostic criteria set forth by the American Academy of Sleep Medicine. So there are a lot of people out there that are very sleepy, that haven't been diagnosed. I think educating the public is very important. In terms of clinical trial design, one of the biggest things that we've run into is that many of people with IH are taking antidepressants or other psychoactive medications, and that often it causes exclusion of these patients, or the people have to wash out of these medicines, which is problematic. So I would advocate for including a lot of antidepressants or other psychoactive medications in the clinical trials. I like the concept of enriched trials. That was what the Jazz Xywav trial was. 75% of people responded to the medication, but 25% were not allowed to continue to participate in the trial. So that's an enriched trial. Minimizing exposure to placebo, I think, is important. Also, offering people the option of open label extension, so that if they do respond well to the medication, they have the opportunity to continue to remain on the medication for a period of time thereafter. That's an important incentive to incentivize people to continue to participate in these trials. But yeah, diagnosis is very important. And fortunately, I'm affiliated with a large sleep center, so that helps. But a lot of sleep centers really don't focus on disorders of hypersomnia. A lot of them just focus on sleep apnea. So there's a lot of people that are underdiagnosed, even though they've been seen in the sleep center. So yeah, that's some of the problems that I see in recruiting and retaining subjects.
Thanks for that. And Dr. Morse, I know that the topic of defining a narrow population for the purposes of achieving more homogeneity between the research participants sometimes is at odds with how that then can be interpreted in the clinical setting. If you're so narrow in the entry criteria, but those aren't really the sort of real world patients that you see every day in clinic, and it can also affect the label of the medication and how it gets reimbursed. So how do you think about this tension between narrow populations and maybe a more real world sample being studied?
Sure. So I think in medicine, we very frequently refer to this as, are you a lumper or a splitter? And very, very frequently I say I live on a continuum constantly, and I will fluctuate in one way or another depending on the situation. And so when talking about conducting research, most will fall to the side of saying we really want to be a splitter. We want to be as specific as possible. However, the innate risks associated with that is that you now are alienating a lot of people who may be living with the disorder and not understanding what the exposure looks like. And so therefore we only learn about that later on through either real world evidence generation or in clinical practice. The secondary piece is that when we are saying that we're going to be a splitter, and we've seen this already repeatedly, even in terms of the study of drugs in narcolepsy, and as Eve had referred, that we know one endotype of narcolepsy type 1, of that there is a specific subset that has CSF deficiency of orexin. And so now we're seeing a very specific study. And with an orexin replacement in someone who has orexin deficiency, that's hugely beneficial, of course. However, when you're looking at prior studies that have been done, such as with oxybate medications, and there has been the evaluation of saying cataplexy is a primary endpoint, although there may have been inclusion of patients who have narcolepsy type 1 and type 2, you then see insurers say, you don't have cataplexy, you don't have you don't have the access to this medication. And so there are innate challenges on all ends of this when you're talking about who you're bringing into the study, and you're now excluding those who in real world, in my clinical practice, this is most representative of, as well as how it has implications in terms of the exposure that Bruce had stated earlier of getting drug, getting placebo, who ends up staying in and participating, to the fact of how do you actually end up prescribing this and getting the drug reimbursed so that people actually have access to it. And so we sometimes are developing clinical trials and creating exclusion criteria in this vacuum to be able to appease the FDA and have their agreement and their approval of use of the medication. But it really is binding our hands to better understand it. And so I agree with Eve in the fact that, of course, we're always driving out how can we create the best science. However, in the meantime, we also have to be quite cautious that we don't end up cutting off our nose to spite our face, because we are excluding and invalidating the lived experience of individuals who truly may have this disorder. And to Bruce's point, although they're characterized as rare diseases, it is with recent evaluation of something like the Wisconsin sleep cohort that gave the suggestion of the 1 to 2% of the population. That means that we are looking at that there are similar statistics to something like epilepsy, where 1% of the US may have something like epilepsy. However, again, this is a heterogeneous. They symptomatically look similar. However, the things that are actually driving at this are different. And if we were to borrow from those types of clinical trials, they generally are saying, do you have clinical features that appear in this way and in this pattern? They're not saying you're excluded based on what your EEG looks like or what your MRI looks like, most typically.
So I appreciate your sense of this fluid movement along the continuum from highly defined populations to more inclusive populations. Dr. DeValier, I saw you shaking your head, maybe in disagreement somewhere along the way, maybe with the prevalence of the condition or other statements. And you know, we don't expect the panel to fully agree on this. So
yes, I love to disagree with Anne-Marie. It's like a game.
It's a hobby.
If you didn't know, it's a French pastime.
That's true. So I think we need to separate. Now, what I said, disagree is a 1-2%, and Bruce said that as well. So MSLT below 8 minutes without SORAM is not equal to IH, and this is mostly what the Wisconsin study and other study report. So For us, in my lab and in most of European lab, we do have some inclusion criteria to have good sleep, etc. I don't want to make a lot of energy on that because it's a number of items, but it's inclusion criteria, not exclusion. In terms of if you are not if you are not with OSAS and you are sleepy, it's IH. But it's not the case. There is many argument against that, but depression, sleep deprived, obesity, even if there is no increased AHI, it's not enough to say that they are affected with IH. This is one point, to be sure of the diagnosis, again, reliability of the diagnosis, and also the prognosis. Can you predict that in 5 years the patient will still be affected with the disease? Because when you start a medication, you never know when you need to stop. For NT1, you will never stop. But for IH, it's unclear. And it's nice to make some good feedback to the patient that after a while, they may be not affected anymore. So no, it's not lifetime disorder for some of them. And we work on that to try to understand who will recover and who will not. This is for the diagnosis. But after for the trial, it's different to make sure that with homogeneous group of again, to be diagnosed correctly with IH, and after to have a nice study design to prove that it works, compared to something which is very hard for the patient, a big effort to jump into the trial, to be exposed to the placebo, and that's very complex. But this is mandatory to be able to have new drugs on the market. That's different than when the drug is on the market, after the physician can play and can use the drugs, even if it's not really exactly the same phenotype as has been tested. But we need to separate for me, what is randomized controlled trial backed by pharma or by academic center, and what is the routine. And the daily life, when you want to treat the patient, is completely different story, because you want to help. It's not that you want to prove that the drug is safe or effective or not. It's second step to help the patient in the routine. But on a daily basis, you need to see the patient on a daily basis. And Anne-Marie is always in the plane, so daily basis never exists for her. I just want to stop here. But daily basis, you need to spend time in your lab. But Anne-Marie, I'm not sure she's even know where is the lab.
Well, we're going to put a pin in that and circle back to a research challenge that Dr. Corser brought up, Dr. Bignot brought up, Dr. Trotti highlighted from the meeting. And Dr. Bailey, I'll go to you first on this. One of the biggest challenges for individuals with IH in participating in clinical trial research is they often have to stop their meds that may be providing some modest relief to them, and coming off those medications can be quite a hardship. So first, how do you help individuals navigate that decision about whether they can, do that? And are there things you do to help support that? Are there other challenges just because of the nature of IH make it difficult for people to participate in research studies that you found in your work?
That's a very great question. I appreciate the question. First of all, research has certain protocols, and there are reasons for those protocols, and we do need to follow those protocols. And if we can find ways to make it easier for patients or suggest changes, we should. What most patients struggle with is okay, what will happen if I come off of these medications? And sometimes it's a deal breaker, to be honest, because most of the patients that we end up seeing who've finally been diagnosed with CNS hypersomnia of some sort have other health issues as well, okay? And if they've been dealing with this for long enough, they may be suffering with depression, anxiety. They may have been diagnosed with even some form of schizophrenia. It gets really, they end up usually on a lot of medications. So, and especially if they've already been treated for narcolepsy or IH, and they're like, I'm good, but I do want to participate in this study. Do I have to come off all my medications? It could really be scary for them. So, and I want to particularly talk about as it relates to those patients in underserved areas, because some patients may have the resources to have the support. If they have to come off their medications, they may not have to go to work, or they may not have children they need to care for, or they may have support. But for those patients who don't have that, it could be really devastating. And one instance, and one thing I bring up in clinical trial research that we do is, what about childcare? You know, if you're going to take someone off their medication and they don't have support with childcare, that could be a serious problem, or it could even be a risk. Transportation is another issue that has to always be considered. And so there are these daily activities that many people take for granted that are very challenging to maintain, and safety issues as it relates to taking people off their medications, whether they're medications for CNS hypersomnia or other medical conditions. And so patients need more support if they're going to be asked to do this.
So you point to a really important part of the clinical trial conduct and the design of studies, the wraparound supports that are available to participants in those studies to make it possible for them to take part. Do other members of the panel have some ideas or experience with things that have really helped to enable people with IH to take part in the studies, or how those conversations go to figure out sort of the risk benefit of participating in a research study?
Well, usually transportation costs are provided by the sponsors, which is a big help. Usually the transportation costs are covered throughout the duration of the trial, but I completely agree that having a support system in place is incredibly very valuable, because these people are often very disabled, especially when they come off medication. So that support system is very, very crucial. I did want to circle back and talk briefly about the social media. You know, this is going to be the future of recruitment for clinical trials. Other sites that I've talked to, or other people involved in clinical trial industry, stress the importance of social media going forward. So I think as a clinical trial trialist, I rely heavily on recruiting people through social media, and this is going to be so important to disseminate information to people with IH. And IH is a diagnosis of exclusion. It's not an easy diagnosis, because you have to rule out insufficient sleep, and as Yves mentioned, there's other conditions that can cause hypersomnia. So it's really crucial to sit down with patients and to evaluate what have they been doing. Are they doing things to sabotage their sleep, that might induce excessive sleepiness? And so it's very important to sit down and really do all the necessary background to rule out other things that might be causing hypersomnia. And to Eve's point, there's European data showing that people with IH, about 20% will have resolution of their symptoms after about a decade. So it really is important to rule out other conditions that might be masking or masquerading as idiopathic hypersomnia.
And Dr. Courser, I recall you stating a few minutes earlier that one way to help patients maybe get over this hump of having to go off their medications is through the trial design of having the open label extension. So if they do benefit from the study medication, they're not then kicked off at the end of it and kind of back to square one with their regimen. Are there other ideas like that that can help make the participation more practical for individuals?
Yeah, these trials, anybody that's participated in these trials or that conducts these trials realize how onerous some of these trials are. There's multiple different measures. There's sleep diaries involved. There's PVT. This is a measure of vigilance. There's multiple questionnaires. So I think trying to minimize the burden on the patient and the staff, because some of these timelines that we have to follow in these trials are quite burdensome, So we have to wake up people at a certain time, and they have to complete certain diaries or questionnaires. So I think it's important to have at least a window of opportunity so some of these patients have severe sleep inertia, or brain fog. So it's sometimes difficult for these patients to complete diaries. So I think a good window of time where people can complete a diary entry is important, and really trying to minimize the overall amount of data that's captured. I realize it's important to capture necessary information, but boy, some of these trials are very onerous and very, very complicated.
Well, you give us a good segue into our sort of lightning round here as we close out our time with you. I'll invite each of you to share maybe one change you believe we could make to IH clinical trials so that they're less burdensome for participants without compromising the data that we know is necessary to understand the benefit-risk profile of the study drug. And Dr. Morse, I'll start with you.
Sure. So one of the things that I would acknowledge is that although what Bruce states of that there's transportation covered, that transportation is specific to going to and from the trial visits. If individuals are randomized to placebo and they now are inadequately treated, we have to think about, is their job safe if they're employed? To Amabi's point, is the children safe if they have children at home? So really thinking comprehensively about what does that person's day-to-day look like, and is it transportation, is it groceries, is it making sure that there's some sort of home health aid to ensure safety for the patient as well as for those who maybe they're a caregiver for. So I think there needs to be the taking the step back of understanding that we are purposely inducing a tremendous disability by asking people to be off of medication and potentially randomizing them to weeks, if not longer, to a lack of medication. So really taking a look at the full person, full life.
And that's where the Voice of the Patient report could be a useful resource in really understanding all the dimensions of impairment that individuals experience. Dr. Courser, how about to you next?
So I think it's, this is to the sponsors and to the FDA. So again, minimizing exposure to placebos, maybe emphasizing enriched trials so people that don't benefit from medication aren't forced to continue to take the medication throughout the duration of a trial, limiting the duration of the trial, offering an open label extension, providing the support, transportation costs, not only to and from the clinic, but also to and from the grocery store or wherever else they might need to go. So all these things are important. And then finally, really reaching out to these patients. These patients are hard to find, but they shouldn't be hardly found. So I think it's important for the clinical trial sites to reach out as best as possible through community outreach to inform people that there are effective treatments, and maybe participation in a clinical trial would be very beneficial.
Great. Thank you so much, Dr. Courser. Dr. Bailey, what are your thoughts?
First of all, I would like to thank, this panel is amazing. It's not the first time I had a chance to hear them, and they all have great ideas. I would just add, one thing I would like to contribute is to really put more emphasis with resources, not just talk about it really reaching out to underserved communities, diversity, equity, and inclusion in clinical trials, both with diverse providers, because, there are providers who are holding it down in underserved areas that have very little access to sleep care, who have access to the patients because the patients trust them. And that's why they would actually participate in the clinical trial. Not just because they saw it on social media, but their doctor spent the time talking to them about, I think you may have this condition, or you really should consider participating in this trial. But the resources in those areas are not the same as the academic centers or the big city multi-specialty groups or whatever they may have. And they may need more support to be a clinical trial site, or those patients may need more research. In fact, there's lack of equity in how much patients get reimbursed based on where they live, if they live in an underserved area versus a major city. And if they are being seen in an academic institution versus a small clinical trial site in a rural area. So I think there needs to be more equity in that, more support to those patients. Because if you imagine, for those who come from these areas who may have narcolepsy or IH, they're living with this they're still working 2 or 3 jobs, or they're still raising 3 or 5 kids, and it's particularly more difficult to ask them to step away from, they're barely holding it together, to step away to participate in a clinical trial. They should be compensated fairly and supported equally, or even more equitably, I should say. So that would be my contribution. What can we do to not just, as Dr. Corser mentioned, find those patients who need to be found, but also find them in the areas where they may be suffering the most.
I'm hearing you say, meet them where they are. Don't expect them to come to you in your ivory academic tower. So thank you for that. Dr. Devoyer, you have the last word to finish us out today.
Yes, thanks. I will, because I'm the last, I will propose a different angles. The different angles is the patient who participates in trial is very lucky because he will be highly educated. Because agree that there is tons of scale, PVT, MWT, actigraphy, whatsoever it is, depending on the trial. But we need to explain why this is mandatory to be assessed at baseline and after being medicated. So you educate the patient about his problem, and he think about, yes, on my daily life, my long sleep duration, my naps, my sleepiness, because sometimes, you just want to be without the disease. So I think it's an opportunity to engage himself about the perception of the problem, the burden of the disease, and that may disappear or at minimum decrease with drug intake. So it's lucky time for him for himself to be engaged, and also to better understand the disease. So he helped for the disease recognition and also to promote potentially drug on the market. So I think I say that all the time. He's very lucky. Sometimes he's not lucky because he's the placebo, but it's the game, It's also to understand that if he's lucky to add drug in the past or to add new drugs when they will be on the market, it's because some other patient participate in the trial. So it's different angle, and you need to spend time to engage and to participate, and not just to put patient in the number 1, 2, 3 and say, you will be randomized with blah, 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 and I have no time because I need to see another patient. You need to spend time. And I know that in US, sometimes time is money and it's hard to spend time with the patient, but in Europe, we are a very rich country and we can spend time with the patient, and they are mostly happy to participate. They come from whole France to see me, and just because we explain, we spend time. Again, academic is different than industry-sponsored study, but it's the same story at the end. We need to better understand the disease and the responders of new drugs in the field.
Well, and your comments really emphasize the benefit of paying it back and paying it forward for the patients who really pioneered the early studies in IH and now have the opportunity to advance the science for the benefit of both themselves and future generations. So thank you for that. Well, we knew this panel was going to go fast, and it certainly did. Thank you for bringing your experience and insights to this discussion and proposing some thought-provoking ideas for ways to make research participation more patient-centered. And I thank you, and now we'll hand it over to Lindsay to introduce our final panel discussion today.
Thank you, Kim, and thank you to all of our panelists. I think some of what we've heard so far today will come together quite nicely in the next session. Immediately following the EL-PFDD meeting, we began hearing from sponsor companies who were recapping that unmet needs that were identified during the meeting and sharing their thoughts about ways to potentially tackle them. Those conversations were the origin point for our next session, which is actually a report out from a set of roundtable meetings held back in December. So I am pleased to have representatives from each of the sponsor organizations that were actively involved in those roundtable sessions. Joining us today are Brian Abeluk from Avadel, Daniel Barzak from Takeda, Salvatore Insana from Harmony, Jessica Sachs from Jazz, Mandy Sturkle from Centessa, and Marcus Yuntz from Alkermes. The full list of participants in the roundtable is available in the program booklet on the page where you accessed today's meeting. We'll hear from each of the roundtable representatives, first describing the roundtable format, followed by themes and ideas generated by that group. Before turning to Mandy to lead this discussion, I'm going to clarify that the concepts of the roundtable that were generated are aspirational. They do not represent a commitment by any company or coalition to pursue. We view this as an important first step towards creating a shared roadmap for progress for IH. Mandy, please share the roundtable structure.
Thank you, Lindsay. So participants in this roundtable convened twice in December of last year for planning sessions. Now, I also want to emphasize that the focus of this roundtable is both pre-competitive and non-product specific. In preparation for these two sessions that occurred in December, we reviewed the IH Voice of the Patient report, and we gave thought to the key challenges and unmet needs expressed by the IH community. As a group, we then collectively reflected on the unmet needs and discussed potential ways to address them, whether that be through new and enhanced endeavors, practices, programs, or policies. We truly took a blue sky approach to these discussions that was unbound by any budgetary or other restrictions. We then refined and organized that list and prepared that for presentation here today. I'll turn it over now to Dr. Insana.
Thank you, Mandy. My name is Salvatore Insana, and I'm on behalf of Harmony Biosciences. And this slide here represents an overview slide of what we're going to be discussing through the remainder of this presentation. So based on the IH community testimony at the April 2024 meeting and the survey results, priority unmet needs in IH fall into these 4 categories. Each of these categories are closely interrelated, and the ideas generated within each actually span multiple categories, so they're overlapping. So colleagues within this roundtable meeting will address each of these 4 unmet needs, beginning at the top with our thoughts about approaches to reduce the lengthy diagnostic odyssey. And now I'll turn it over to my colleague, Jessica Sachs.
Thank you, Sam. So as Sam just mentioned, one of the key themes that came through both the PFDD and the Voice of the Patient report was that reducing that lengthy diagnostic odyssey is a top priority, and it is truly an odyssey. You heard Dr. Trotty discussing the multi-year gap between symptom onset, seeking medical attention, and diagnosis earlier today. But there's a number of ways to help shorten this diagnostic delay, and several ideas emerged during our group brainstorms. For example, we know there's challenges and limitations with current screening and diagnostic tools. So further enhancing the clinical utility of existing tools like actigraphy, which is in the diagnostic criteria, may help support and add confidence in the diagnosis of idiopathic hypersomnia. Additionally, further developing newer sleep testing protocols that can aid in the differential diagnosis of IH, particularly from narcolepsy type 2, would be incredibly productive. And I think many of us agree the big pie in the sky goal is to ultimately identify a biomarker that could be truly diagnostic of IH and aid in research. We also discussed the need to better characterize how both patients and providers describe and communicate the symptoms and impacts of idiopathic hypersomnia in order to further validate and solidify IH as a distinct sleep disorder deserving of its own recognition and treatment considerations. And along those same lines, educational initiatives that increase awareness of IH among both sleep specialists and broader HCP groups were proposed, including things like bite-sized training activities, such as short videos or infographics and clinical interview decision trees to aid in the recognition or when to refer to a sleep specialist, as well as payer education initiatives to help improve access to and reimbursement for formal sleep testing, which we know is a challenge in and of itself. And finally, patients, of course, should feel empowered while they are seeking answers during their own journey. So making self-assessment tools easily accessible and approachable may help jumpstart their own awareness of IH and support those early conversations with their doctor. And now I'll turn it over to Dr. Marcus Juntz to talk more about considerations once a patient is diagnosed with idiopathic hypersomnia.
Excellent, thank you. And yes, so the next thing we talked about really was how we could help people with IH potentially obtain quality care in a timely manner. So what kind of ideas might the field be able to implement? And it really fell into a few categories. One of the biggest problems, which obviously is not going to be a surprise for anyone on this call, is that there is a significant shortage of physicians who feel comfortable caring for people with complicated sleep disorders like idiopathic hypersomnia. And on top of this, at least in the US, there's a geographic imbalance of these providers that really can further amplify that problem. So one approach we discussed a lot and has actually come up on this call earlier is the idea of expanding the use of telehealth for these people with IH. It's a complex issue. It's being talked about in a number of fields of medicine, but we do think it could be particularly helpful here. And then similarly, as you all know and has been discussed, idiopathic hypersomnia impacts people in many ways, with school, with work, with relationships. And we think that establishing central centers of care where people can really access physicians, but also clinical trials, social supports, patient support groups, all in one place would really go a long way to making sure we're treating all aspects of the condition. And then similar to increasing access to trials for new medicines, the other big category we discussed was increasing access to treatments that are already available. And of course, this is quite a complex issue. We had a number of discussions on this. One example that we considered was continue to collect data about how treatment of IH improves many aspects of a person's life. This could then be used to educate various parties, such as payers, in order to hopefully maximize the treatment options available to people with IH. And really, this education should also involve highlighting all the other things that people with IH often face as well, things that were mentioned, such as depression and anxiety. So we need to make sure these are also being adequately addressed. And then finally, of course, it's always useful, we think, to have a friend, a family member at care visits, both as a listener, but as has been discussed earlier, as someone who can really describe what they're seeing happening in someone's life to hopefully make sure that that's being settled as well. So we did think these were a number of concrete activities that could help to increase access to quality care for people with idiopathic hypersomnia. So now I'm going to turn it over.
Wonderful. So, hello, good afternoon, everyone. So today I want to talk about like how we can better understand idiopathic hypersomnia and improve the social supports for those living with this condition. First, one of the points that we discuss is that we really need to increase public understanding and awareness of IH. So imagine if patients had resources that could share with their families, friends, employers, and school staff. These resources would help others understand that what IH is, and why support is so crucial. So it's also important to validate the need for family and other supports, because having a strong support system can make a world of difference. Additionally, we discussed that we need to develop messaging that enlightens those who might make dismissive statements about the condition, helping them to see the real impact of IH has on people's lives. Next, we not only need to understand, but we must seek a better understanding of cultural differences in how patients experience and also articulate their symptoms. For instance, an example, terms like depression or even brain fog might not translate well into other languages, which can affect how symptoms are understood and also communicated. So by recognizing these cultural nuances, we can provide better support and care for patients from diverse backgrounds. And lastly, it's important to develop resources and support to aid with the coordination of care, especially for young adults. Given that IH often begins and worsens exactly during young adulthood, and many young people are not familiar with navigating the health system care, having these resources can be incredibly helpful. So summarizing, by focusing on these areas, we can enhance and understand of IH, or better understanding of IH, and provide a better social supports for those that are affected. So now I hand it over to Brian, if I'm not wrong. Brian?
Yes, thank you. We also talked about how we can expand research focused on idiopathic hypersomnia. In terms of outcome measures, the world is changing, devices are getting more sophisticated. We want to leverage advances in technology like EEG and actigraphy to understand what happens over the course of the day and not just in the sleep lab. We know that IH is not just sleepiness. We talked about better ways to capture other symptoms that are really disruptive to patients with IH, like fatigue, brain fog, and sleep inertia. We want to make the most of real-world data sources like testing and claims data to inform broader research. That said, in terms of understanding each patient one at a time, we know it's a lot to come to the clinic for frequent research visits. We need to find ways to meet patients where they are, and especially as technology gets better, we'd hope to gather data from patients at home. But of course, we need to do that in a way that respects privacy. In terms of functional impairment, we talked about shifting our thinking, as you heard from Dr. Trotty and Dr. Plant and Dr. Morse, from looking not just at sleepiness and measuring symptoms, to really seeing how we can help patients live as happily and productively as possible. We need to think about patients' number of hours of quality wakefulness, and we should aim to understand how we can improve quality of life. We talked about strengthening epidemiology around IH and seeing what each patient's unique trajectory looked like. We also discussed industry-led consortia to spearhead pre-competitive research-related advancements. Finally, we continue to keep front and center that patients signing up for research, whatever the setting, are always executing an act of generosity.
Thank you, all of you, for your work by this roundtable group. I'm struck by how aligned these ideas are with the voices of the people living with IH. It's also very responsive to the topics that we've discussed in today's meeting. You have created a remarkable and meaningful set of possibilities for us to collectively roll up our sleeves, prioritize, and get to work on.
Wow, Lindsay, that was a dense set of discussions, leaving us with so much to think about. And the panelists and presenters brought additional light and a little bit of heat to just a subset of the topics that came up at the ELPFDD meeting and survey. I hope it was an additional learning experience for all the stakeholders at today's meeting. Some nearly 400 people signed up for today's session, representing people living with IH, caregivers, researchers, healthcare professionals, and staff from life science companies and federal agencies.
I agree. When we first began discussing this initiative nearly 2 years ago, I don't think Claire and I could have predicted the generous response from all corners of the IH community to be a part of an effort to move IH out of the shadows, to bring the lived experience of IH into the light, and then to focus our attention on how to address research and other unmet needs based on what we've learned from the community.
You know, we've heard from so many people with IH about how validating this initiative has been and how much hope it's really inspired for them.
Before we close today, I wish to extend our profound thanks to the presenters, panelists, sponsors, and partners who joined us for today's session. Thank you to the FDA for the continuing interest in IH and the early input that helped shape today's agenda.
And as a reminder, the recording of today's meeting is available on demand now, and it will remain available at the same link you are at today. Please share this with colleagues, family, friends, and other community members who could benefit from today's conversation.
The comment form will remain open until February 28th. We regret that time did not permit us to share live, but they will be reviewed and will inform the meeting summary that will be published this spring. This is an exciting time for the IH community, and speaking on behalf of Sleep Consortium's co-founder, Claire Wilds-Bright, and myself, we could not be more proud of all the work that you've done today to illuminate hypersomnia.
And with that, it's my privilege to close out today's session. Thank you to the entire team responsible for putting this program together, especially our panelists and presenters, and most of all to the IH community members for your perseverance and commitment to forge a better future for all affected by IH. With that, I'll wish everyone a good rest of your day and your evening. Thank you for spending part of it with us today.